like to call the meeting of the Health and Human Services Committee to order. It's Tuesday, March 5th, 2024. We have a quorum present and we have a full agenda today, so I would like to get started. First, we have Senate File 2982, Senator Boldon. And the bills today will be going different places. I guess most of them will be bills that we have to pass out of our committee and move along to another committee stop. Senator Boldon's bill, the 2982, will need to go to the Judiciary Committee. Welcome, Senator Boldon. Please proceed.
Thank you, Madam Chair. I do have an A1 amendment.
Senator Boldon has the A1 amendment for Senate File 2982. Members, all those in favor of the A1 amendment, please signify by saying aye.
Aye.
Any opposed? The amendment the motion does prevail. The amendment is adopted. Thank you, and please proceed.
Thank you, Madam Chair and committee members. And just to note that that A1 amendment that we just adopted is a technical amendment to get it in the shape that I would like to hear it. So thank you for hearing this bill this morning. I want to also thank Senator Hoffman for being a co-author on the bill. So this is a bill around speech language pathology assistance. And so these are folks who provide services to remediate communication issues related to articulation, language, or voice impairment under the supervision of a licensed speech language pathologist. So this legislation would enable licensure requirements for speech language pathology assistance, which would be administered by the Minnesota Department of Health. This language also clarifies current state law governing supervision of speech language pathology assistance. It would increase the ability for an SLP to supervise 2 assistants versus just 1. It also clarifies that that supervision can be in person or using real-time, two-way interactive audio and visual communication. So members, this speech language pathology assistants provide care in acute rehab hospitals, outpatient clinics, schools, nursing homes, private pediatric practices, autism programs, and other medical facilities. And this is a workforce issue. We have needs for these services across our state, and enabling more folks to come in and to be able to do this work will help to meet the needs across our state. There is certainly more support needed to serve a growing and diverse client base and address the severe and growing shortage of speech language pathologists in medical schools and medical settings. So by utilizing a qualified speech language pathology assistant, supervising speech language pathologists can then extend their services to increase frequency and intensity of services to patients or clients on their caseloads, or focus on more professional work and expand in other ways. According to the American Speech Language Hearing Association, there are 17 other states with licensure requirements for SLP assistants in a medical setting, and 11 other states with licensure requirements for SLP assistants in an education setting. I'll also note this is a similar structure. This assistant licensure is similar to occupational therapy assistants and physical therapy assistants that is already in place. So members, I do have a testifier and look forward to questions and discussion and would ask for your support. I would just say on a personal note, the speech language pathology profession is important to me. My youngest son, when he was a toddler, had difficulty making some of his sounds pretty significantly, and we were able to get access and get him care. And by the time he started school, you would never know there was an issue. And so I want, everyone deserves to have that specialized care, and so we want to be sure that we have enough folks in the workforce to be able to meet the needs for everyone across our state. So I would ask for your support. Thank you.
Thank you. Welcome to the committee. Please state your name for the record and begin your testimony.
Thank you, Chair Wickland. My name is Nancy Toole, and I am a speech language pathologist. I'm here representing the Minnesota Speech and Hearing Association. I am the most recent past president, and then I am also the SLPA, Speech Language Pathology Assistant Program Director at Alexandria Technical and Community College. We are the only program in the state of Minnesota, and we've been in existence for 10 years. As an SLP, speech language pathologist. I have a master's degree and my C's, which is a national certification. An SLPA can either have a 2-year degree that's specific to speech language pathology assistant, or they can have a bachelor's degree in undergrad in speech language hearing sciences, and then a certificate through a program such as ours at Alexandria Technical Community College. I'm telling you the difference because a speech language pathologist is able to diagnose and treat people with speech language and communication disorders and swallowing disorders. An assistant is someone who would be able to treat disorders in the area of communication based on what I would provide them with for a treatment plan. Both an SLP and an SLPA can work in a medical setting, and they can also work in a school setting. Not licensing SLPAs puts a barrier up for hiring SLPAs within a medical setting. And first we need to make sure that these people are qualified and highly trained, and licensing is a way to ensure that. If they're licensed, they would be able to bill for their services, which is also a need in the medical setting. And as she had said, there's a severe shortage of speech language pathologists. It's in our state and it's in every state. And that has been ongoing for many years, and it's just getting worse. So the state of Minnesota started the SLPA program in ways to help serve the needs of those with communication disorders in our Minnesota citizens. We want to do no harm, so we want to make sure that these people that we put in front of those with communication disorders are highly trained and specifically trained. They need to be able to serve those with the highest, most training that they have. We want, like I said, like she said, there can be barriers for time. If an SLP doesn't have enough time to see a child regularly, that cuts into other time for evaluations. Things get backed up, and we just need to have more services available. We want the SLPAs to become, to lighten the barrier right now for those patients that need services in the area of speech and language. Thank you for your time.
Thank you. And that's the only testifier I've listed, is that correct? Okay. Members, do you have any questions about the bill? I'll ask one question. In terms of the supervision of the assistants, it looks like you're adding, I think, some training for requirements for the SLPs to, be able to do the supervision. Can you talk a little bit about the supervision work that they do and how
Sure.
that collaboration works with the assistants?
At the same
Ms.
time
Toole?
that the program at Alec Tech was started, we launched also a 10-hour supervisory course for SLPs who would be supervising SLPAs. In that 10-hour course, which is online, work at your own pace, the SLP learns more about the background of an SLPA. They learn about their scope of practice. They also learn about what they can do and what they can't do. We also give them several examples of how to supervise or set up a schedule when you're working with an SLPA. It isn't cookie cutter. Some speech therapists strive to 4 schools in a day. We talk about in that class how they can rearrange their schedule so that the SLPA is used to the maximum. And we talk about not only scheduling, but the qualifications of an SLPA, so that we make sure that if they're working with somebody, that person has had adequate training. What we don't want is to put somebody in front of an SLP who's already super busy, and then they have to train this person, or they're responsible for them and something goes wrong. They need to know that this person has been highly trained. So they do take the 10-hour supervisory course, and it's through Alexandria Technical and Community College. And I've been doing it for 10 years, and the feedback I get is very, very positive. They are so thankful that they've had something that gives them all the tools necessary to supervise somebody effectively.
Thank you. Senator Morrison?
Thank you, Madam Chair, and thank you, Senator Boldon, for bringing this forward and to the testifier. I'm just curious, it seems like this bill has been around for a long time. Why is that? What has the holdup been?
Well,
Ms. Toole?
Thank you, Chair. We were making great progress, and then COVID hit. I don't know much more than we have been having no opposition. We just haven't been able to push a licensure bill through on the House side, and that's kind of where it stopped.
Senator Morrison? Any other questions? No? Senator Boldon, any other comments?
Madam Chair, the last thing I just would say is, as we as a committee are looking at more ways to get more care to more folks, really work on those access issues and workforce issues, this is a bill that can help us to do both of those things.
Thank you. Yeah, and I appreciate you bringing it forward. I was involved in the bill a few years ago, and we weren't able to get it done. I think it's a really good idea, and I think the way that it is helping SLPs to be able to extend their ability to serve more people is really important, since we know that there's a shortage. So thank you for bringing the bill forward. And members, the motion, Senator Boldon, would be to recommend that Senate File 2982 as amended be recommended to pass and be referred to the Committee on Judiciary and Public Safety. Would you like to make the motion? And members, all those in favor, please signify by saying aye.
Aye.
Any opposed? The motion does prevail. The Senate File 2982 as amended is passed and referred to the Committee on Judiciary and Public Safety. Thank you. And you have another bill, Senate File 1743. Please proceed.
Thank you, Madam Chair and members. So we'll change gears a little bit here, but still addressing access to care. So I'm pleased to present Senate File 1743, which is the Minnesota Certified Nurse Midwife Practice Act. This is a bipartisan bill that was initially carried by Senator Coleman, and Senator Abler is currently a co-author, so thank you for that. The United States and Minnesota have a maternal health crisis that is causing high levels of maternal morbidity and mortality. And we know that there are stark racial disparities, and large areas of greater Minnesota can be considered maternity care deserts. You'll hear more about Minnesota's racial disparities from our testifiers, so I want to give you some ideas about our maternity care deserts. According to the March of Dimes report in 2020, about 20% of Minnesota counties are considered maternity deserts, based on availability of birthing facilities, maternity care providers, and percent of uninsured women. And I'll note that problem is getting worse, not better. Pregnant women in greater Minnesota are having to drive greater distances to get care. Maternal mortality statistics from 2017 and 2018 indicate that 48% of pregnancy-related deaths occurred in greater Minnesota, even though greater Minnesota residents only make up 1/5 of the pregnant population. Maternity deserts in Minnesota are a serious barrier to accessing safe care. The situation will only become more desperate as 1/3 of Minnesota's midwifery workforce is anticipated to retire within the next 5 to 10 years. So expanding access to midwifery can help to increase access to more maternal health providers and maternal care. Certified midwife licensure is an evidence-based strategy that we can implement in Minnesota to expand our midwifery workforce, increase diversity in our workforce, and help address maternity care deserts. Certified midwives are not new to the United States. They are practicing in 12 other states and have been practicing in some states for upwards of 30 years. By establishing licensure for certified midwives, Minnesota will be introducing a new way to become a midwife. With passage of this bill, Minnesotans will be able to become a midwife without first becoming a registered nurse. To graduate from a certified midwife program, a candidate will have to complete the same science prerequisites, will have the same graduate level midwifery education, and pass the same certification boards as nurse midwives. The midwifery scope of practice for licensed certified midwives will be the same as certified nurse midwives. The University of Minnesota is poised to start a certified midwife program in the University of Minnesota midwifery program, but it doesn't want to start a program until they can grant licensure. This bill will also mean that those precious RN educational seats will be reserved for people who truly want to be nurses, which is something that we very much need. The Board of Medical Practice and the Board of Nursing have met and support certified midwives being licensed under the Board of Nursing to ensure consistent application of the regulatory requirements. There are no opponents, and many supporters have submitted letters that are included in your packets, members. So with that, I do have a couple testifiers and look forward to questions.
Thank you. Do you know which testifier would like to proceed first? Or I have Rebecca Polston listed.
Thank you, Senator and
Please
members.
state your name for the record
Sorry,
and begin.
my name is
That's
Rebecca
okay.
Polston. I am the founder and owner of Roots Community Birth Center, a nationally recognized freestanding birth center located in North Minneapolis, and one of the very few Black-owned birth centers in the United States. I'm here to testify in support of the Certified Midwife Practice Act, Senate File 1743. As you may remember, I was here last week as a certified professional midwife, which is my current designation. Minnesota suffers from among the worst rates of health disparities in the country, including in maternal health. Black women in Minnesota are 2 to 3 times more likely to die in childbirth than white women. While just 6.4% of Minnesotans are Black, they represent 15% of maternal deaths in our state. Maternal mortality and morbidity are also rising overall in the United States and increased sharply during the first year of the pandemic. The good news is the majority of these maternal deaths are preventable. We can enact common sense policies to improve maternal health outcomes and reduce disparities in our state, and Senate File 1743 is one prime example. This bill would remove the barrier to certified midwife licensure in Minnesota and expand access to high-quality, culturally competent midwifery care in our state. The certified midwife legislation would not only expand access to midwifery care in our state, but also further diversify it. Research from other states indicates that the certified midwife licensure leads to greater ethnic and racial diversity in the midwifery workforce. At Roots, we predominantly serve patients of color and are proud that our midwifery care model is nationally recognized for cultural competence and high-quality birth outcomes and strong patient satisfaction. The certified midwife legislation would provide a new pathway in Minnesota for aspiring midwives to pursue rigorous training and education without shouldering the unnecessary financial burden of obtaining a nursing degree. As an employer, this would increase the available staff that I could hire. Currently, certified professional midwives are not federally recognized and therefore not eligible for HRSA employment and student loan forgiveness. This would enable us to be more competitive in hiring the very diverse workforce that we need to do our work. Personally, I would be thrilled to pursue this certification to enhance my skill set and offerings and to be a part of solving the larger problem in Minnesota. I'd like to thank Senator Boldon for bringing this important legislation forward and urge the members of the committee to support the file. Thank you.
Thank you. And are you also planning to testify, Ms. Huber?
So we have Siri Fiebiger on Zoom.
We have one Zoom testifier. Would you like to go to that person next? I have Dr. Siri. I'm sorry, I've heard her name before. Is it Fiebiger?
Yes.
If you could please state your name for the record and proceed with your testimony.
Good morning. I'm Dr. Siri Fiebiger, representing the Minnesota section of the American College of Obstetricians and Gynecologists. Senate File 1743 is our single legislative priority this year, as it will help address critical maternal health needs by creating this new avenue for midwifery licensure. Certified midwives, as you've heard, adhere to the same competencies and certification as the highly qualified certified nurse midwives. Midwives have extensive training in low-risk pregnancy, vaginal birth, and well-woman care, and are well-grounded experts, providing integration to higher levels of care as needed. My 25 years collaborative integrative practice with midwives in Fargo-Moorhead made me a better obstetrician and optimized all of our patients' outcomes. Expanding patient access to high-quality midwifery care is both cost-effective and demonstrably beneficial to maternal health, with lower cesarean and preterm delivery rates and higher birth rates and higher breastfeeding rates. Experts from the University of Minnesota School of Public Health recently reported that incrementally increasing midwife-led care over the next 10 years could result in 30,000 fewer preterm births in the US and $4 billion in health plan savings. States with expanded midwifery access have better maternal and newborn outcomes. For Minnesota specifically, you've heard that adding the less expensive, more accessible CM licensure would help expand our workforce, as 1 in 5 counties do not have a provider. And these maternal health deserts do coincide with the health inequities seen in Northwest and South Central Minnesota. Too many mothers in the US and in Minnesota die from preventable pregnancy-related complications. And despite exorbitant and rising medical costs associated with giving birth, the US has the highest rate of maternal mortality among industrialized nations. And our research argues that fully 80%, 4 out of 5 of these deaths, are preventable. This is a critical issue for all women, but especially women of color, as you've already heard. Due to the cumulative disadvantages of systemic racism, women of color face far higher rates of pregnancy-related complications and death. Our Minnesota mothers of color have a 2.7 higher chance of pregnancy-related death, and our Indigenous mothers a 4 times greater chance of death than our white mothers. And this is regardless of education, socioeconomic status, or occupation. And our mothers know these numbers. Their well-grounded fear obvious in their eyes when they first see me, a white provider, walk into their hospital room. Midwives can help provide patient-centered and culturally appropriate care before, during, and after birth. For women of color, especially, holistic care models that include midwifery can counteract some of the disadvantages of systemic racism, as you just heard in our own Roots Birth Center. The outcomes of the Roots collaboration show that midwifery has measurable positive impacts on the subjective and objective experience of birth for women of color. Dedicated to the improvement of women's health, ACOG advocates for legislation that confronts these issues and promotes the health, well-being, and dignity of all women. Women should not fear that they will not be seen, heard, and cared for. Increasing culturally competent and integrated midwifery care is a critical part of our collaborative work with family medicine and with midwifery to have the right provider in the right place at the right time across the state of Minnesota. Thank you.
Thank you for your testimony. Do you have other testifiers? No. Okay. We'll go to member questions. Members, do you have any questions or comments about the bill? Senator Abler.
Well, thank you, Madam Chair. And this is, the testifier said it really well. It's remarkable the difference that this level of attention can be for access and everything. This is a really good project. I'm glad finally got an author who could get it done. So happy to cheer you on. So thank you very much. And to all the people engaged at every level of this, this niche, it's really important. Thank you.
Thank you. Senator Mann.
Thank you, Madam Chair. Great bill, supported. Just have a couple questions. The licensed certified midwife is going to be housed under the Board of Nursing, but not subject to 147D, which is where the traditional midwives are housed. Why did we make that choice?
Thank you, Madam
Ms.
Chair.
Huber, please state your name for the record. And
Mandy Huber, nurse midwife, representing the American College of Nurse Midwives of Minnesota. Excellent question. You've explained it all very well. The certified midwife will be licensed by the Board of Nursing in Minnesota, and that is an ideal place that is supported nationally by the American College of Nurse Midwives, that certified midwives be regulated by the same board that licenses the certified nurse midwife. It is the same scope of practice, and it needs to be regulated by the same body to interpret the laws the same. The licensed traditional midwives are under the Board of Medicine and has traditionally been there. Their practice is different, the scope of practice is different, and so it's okay that the regulations are overseen by a different body.
Senator Mann.
And can you just kind of highlight the differences exactly between the two? Just high level.
Ms. Huber.
Excellent question. So certified professional midwives are a type of midwife practicing in Minnesota. They fall under the traditional midwife 147, as you alluded to, Senator Mann. The pathway is a little bit varied, and there is a national certification. The scope of practice does not include prescribing, managing, or diagnosing conditions. In contrast, certified nurse midwives and certified midwives are under the American College of Nurse Midwives. We sit the same boards. We are regulated typically by the same licensing agencies, and we have identical scope of practices, including, as you see in the bill on page 2, managing, diagnosing, and treating women's primary health care, including pregnancy, childbirth, postpartum, care of the newborn for 28 days, family planning, partner care management, and gynecological care of women across the lifespan. So there are different scopes of practice.
Senator Mann?
Madam Chair, and one last question. You kind of answered it, but I see that the licensed certified midwife was added under the prescribing subdivision to prescribe controlled substances. What, is there a significant difference in training? So, because the traditional midwives are not allowed to do this. What is the, for that specific pharmacology, what is the training difference?
Ms. Huber?
Thank you. The pharmacology training for the certified midwives is identical to those of nurse midwives. Nurses do not learn to prescribe in nursing school. That is training that occurs in the graduate level midwifery education. Because the midwifery education is identical between certified midwives and certified nurse midwives, that is where we learn to diagnose, that is where we learn to prescribe. Typically, controlled substances are used, for example, in postpartum if there's a very extreme tear that needs recovery time and a little extra managed care.
Senator Mann?
Thank you, Madam.
Any other member questions? Seeing no other questions, I don't have any questions. I have also been involved in this bill for a number of years and appreciated getting to know some of the people involved, and appreciate that this would be a way that we can take an active role in trying to address maternal health outcomes in Minnesota. We have a lot of work to do, and it seems like this is one way of, different ways that we can address that. So I appreciate your work on this, Senator Boldon. This bill also needs to go to the Judiciary Committee. So your motion would be that, or do you have any final comments? I'm sorry.
That's okay, Madam Chair. Just very briefly, I think the testifiers said it very well, as did you, and so thank you for that. This is a bipartisan bill. Thank you to Senators Morrison and Abler for being co-authors, and want to recognize that a lot of work has gone into this over many years, so I'm happy to just be, having the baton to move it forward at this point in time. Certainly there are significant issues across our state that this bill would help with in a meaningful way, so I appreciate member support.
Thank you. So the motion would be for Senate File 1743 to be recommended to pass and be referred to the Committee on Judiciary and Public Safety. Is that your motion?
Yes, Madam Chair.
All members signify by, or in support, signify by saying aye.
Aye.
Any opposed? The motion does prevail. The bill is passed and referred to the Committee on Judiciary and Public Safety. Thank you. And now we will move to Senate File 3611, Senator Mann. And Senator Mann, when you're ready, if you'd like to present your bill, I see there is an amendment. Would you like to adopt it as an author's amendment?
I sure would, Madam Chair.
Senator Mann moves the A1 amendment. Members, this is an author's amendment. All those in favor, please signify by saying aye. Aye. Any opposed? The A1 amendment is adopted. Senator Mann.
Thank you, Madam Chair. Members, Senate File 3611 is a bill to change how we license internationally practicing physicians. So right now, if you are practicing medicine in another country, and you could be practicing for 20 years, When you get to Minnesota, you cannot practice medicine until you have, one, passed all of your STEP exams. These are 3 exams that you have to take, and they basically assess medical knowledge. And then 2, you have to go through residency all over again. Residency is the traditional 3 to 7 years of training that physicians get right after medical school. So having to do residency all over again is not only unnecessary repeated training that physicians have already done, but it is a barrier to getting qualified, competent doctors back out in the field. It may sound like no big deal until I tell you that there are not enough residency spots for the kids graduating medical school in America, much less for people coming from outside. So we are preventing people from practicing medicine because there are no residency slots, not because they don't know how to practice medicine. It's estimated that there's about 220 to 300 physicians right now ready to practice medicine in Minnesota, but cannot because of these current requirements. So what this bill does is to remove the residency requirements and replaces it with other requirements. So an experienced practicing medical doctor will be eligible to practice in Minnesota if they have graduated from medical school. They have been practicing medicine for at least 5 years in their home country. They come here, they pass all 3 STEP exams, and they practice in Minnesota in a rural or underserved area under the supervision of a physician for 2 years. If all these requirements are met, then they will have a license to practice medicine in Minnesota. And this will do 3 things for the state of Minnesota. 1, it's going to diversify our workforce. It's going to increase the numbers of doctors practicing medicine, especially physicians in rural areas and underserved areas. And it's going to open up residency slots for newly graduated medical students who need the training. So I will also note that we are not the first state to do this. With that, Madam Chair, we have some testifiers.
Thank you, Senator Mann. I have listed as the first testifier on Zoom, Mike Zimmer. Is that correct?
Yes, thank you. Thank you, Madam Chair.
And please state your name for the record and begin.
Yes. Thank you. My name is Michael Zimmer. I'm a senior policy consultant at World Education Services, testifying today in strong support of Senate File 3611. WES is an entity, works with institutional partners, community-based organizations, and policymakers to help immigrants and refugees who hold international credentials fully utilize their education and training. As Senator Mann indicated, a large number of states are currently exploring legislative reforms to harness the skills and talents of international medical graduates. Legislation has already been passed in Washington, Colorado, Tennessee, Idaho, and Illinois. Legislation has been enrolled but not yet signed by the governor in Florida. And yesterday, Virginia Senate passed House Bill 995, and it's on its way to the governor of Virginia. I would also note that legislation is already pending in legislatures in Arizona, Massachusetts, Wisconsin, West Virginia, and of course Minnesota, as well as expanded pathway that's nearing completion in Idaho. Legislation has also been introduced in Georgia, Iowa, Kentucky, and Maryland, and is expected to be introduced this week in my home state of Michigan. The vast majority of these bills enacted and pending are referred to as sponsorship pathways. Like Senate File 3611, the bills will create a pathway to licensure that establishes specific eligibility criteria and relies on applicants having a firm offer of employment from an approved health facility. Following completion of the limited licensure period and assuming successful performance of those duties, under the collaborative agreement, the employee is eligible for licensure. While Senate File 3611 follows the track of the typical sponsorship pathway bill, it includes a number of innovations and important additions. First, it requires service in a rural or otherwise underserved urban community. And secondly, it specifies in excellent detail the components of the collaborative agreement under which the IMG and the supervising physician operate. Senate File 3611 will permit previously licensed IMGs to work under the supervision of fully licensed physicians to meet the healthcare needs of the state residents, while providing safeguards to assure that the health and safety of patients is preserved. Chair and member of the committee, thank you for affording me the opportunity to provide testimony and offer our strong support for this important legislation. Thank you.
Thank you for your testimony. I showed 2 different testifiers. If you, whichever order you'd prefer to go in, please state your name for the record, and then you can begin your testimony.
Thank you, Chair Wickland. My name is Sarah El-Trafi. Thank you, committee members and Vice Chairman. I graduated from Sudan. I studied medicine in the leading university there in Khartoum University. After that, I finished, moved to Saudi Arabia where I practiced in a community hospital that catered to underserved and rural areas. In that time, I was also recruited to work by the leading research hospital there in Saudi Arabia as a clinical research coordinator. During my time there in Saudi Arabia, my father was always pushing me to come to the United States to pursue my career, as it is the land of innovations, and it's where healthcare providers can get the best training possible. Unfortunately, coming here was not the case for me so far for my journey. I moved to Minnesota in 2013 and to pursue my career, advance my skills. So Minnesota has been a very welcoming place for me, and it's where I see my family growing. It's just that trying to relicense here in the U.S. has proven to be one of the hardest and most challenging journeys of my life. Similar to all medical graduates, we all had to go through the exams, licensing exams, residency applications, in the hope that this dream of being a provider here in the United States would come true. This not only took 11 years from my life as not practicing medicine, but it had also a massive impact on me financially as well. Having such a bill in place 11 years ago would have made a huge difference for me. I would have been a fully practicing physician by now, because for us, like international medical graduates, this will eliminate that need for the application of residency that is unknown. We do the exams, but getting into residency, we apply for cycle after cycle, year after year, and we get rejected. And that happened in my case as well. So the underserved and rural areas of Minnesota is where healthcare is most needed. I have come from a place where I have seen people suffer from not having access to healthcare. That is the main reason why I am standing before you today. I'm here today. My case, similar to many international medical graduates, is a huge loss of potential, honestly. It is a loss to Minnesota's healthcare system and in the U.S. in general. So having such a bill will be a step in the right direction to rectify this. I am truly grateful I was given this opportunity to speak in front of you today. I hope you will support this bill, not only to help other immigrant providers like me, but also to ensure the prosperity of healthcare in Minnesota. Your patience and listening to me is much appreciated. Thank you so much.
Thank you very much. Dr. O, if you could please state your name for the record.
Thank you so much. My name is, I'm Dr. Mimi Oof. I'm a physician from Burma. And thank you, Madam Chair, and everyone in this room for allowing me to testify. It is an honor for me. I came to the United States many years ago, and I came to Minnesota in 1993, so I consider myself a Minnesotan, more or less. I have more than 13 years of clinical experience when I first came to the U.S. And also, I went back to Uganda to practice as a UN physician, which had more than, I catered to more than 2,000 expatriates as well as UN staff. And then I had to come back to the U.S. because at that time I was not a citizen yet. So in order for me to be a citizen, I came back to the U.S. And when I came back to the U.S., I passed all the required United States medical licensure exams, USMLEs, to be able to apply to a residency. So when I did apply to residency and they said that, oh, you have such an impressive CV, you were a UN physician. However, in the end, when it comes to the residency post, they say that, oh, you don't have US clinical experience, number one. Mm-hmm. Number two, you graduated a long time ago. Mm-hmm. The fact is you have to take the US MLEs, the current ones, but the programs do not take that into consideration. They look at the year that you graduated a while ago. Like Senator Mann has said, you graduated 20 years ago, 13 years ago. However, you have a current knowledge. That is never taken into consideration. When you apply for residency, your CV is kind of, the software will take your CV off if you are more than 5 years from graduation. So how is that fair? So I never had the chance to get into a medical residency. I'm here on behalf of other international medical graduates. And also, I wanted to bring forth the shortage is, the physician shortage is not an actual shortage, like Senator Mann has said. It is the training position shortage. It is capped by Medicare since 1997. So we do not have enough residency training positions. In fact, according to the National Resident Match Program, in 2021, we had 7,409 unmatched U.S. citizen medical graduates. In 2022, 6,863 U.S. citizen medical graduates unmatched. The last one is more than 5,000 unmatched citizen medical graduates. I'm not making these numbers up. It's from the National Resident Match Program. So we are wasting about $1 billion every year because one doctor can earn $250,000 per year. So if you have about 5,000 of these unmatched medical doctors, we are wasting on top of the shortage the healthcare needs. So this is such a travesty. And also, in regards to the immigrant medical graduates, we come from diverse populations, and we do identify with the diverse populations. For example, I'm from Burma, and then we do have in the rural areas, like Wilmar, Minnesota, Worthington, Minnesota, Austin, Minnesota, we have several Karen Burmese populations who will be happy to see a Burmese doctor because we understand their needs. For example, I want to tell you a quick story. For instance, if a Burmese patient comes with high blood pressure comes to you and say that to a regular doctor, the doctor will say, have you been adding salt to your diet? And the patient will say, no, I have not been adding salt. But if you see a Burmese doctor, the Burmese doctor will say, have you been adding fish paste, ngapi, to your diet? Of course, I eat this every day. That is jam-packed with salt. So these are the nuances that a diverse doctor would understand. So you will be reducing health disparities, and then you can go to the rural areas. About rural areas, for us who comes from other countries, rural United States, there's nothing rural about it. There's water, there's electricity, there's transportation. So for us, real rural areas are those where you have no lights. You travel on a bullock cart to go deliver a client. That's what I did when I first started. And also, Minnesota, I'm so proud to be a Minnesotan. Minnesota was the first one to do the IMG bill in 2015. Senator Abler was the first one to introduce that bill. However, having said that, it's still not enough because we don't have enough training slots. Now, Senator Mann is introducing something that will change it, and all the international medical graduates will be able to train in hospital settings, clinical settings, and that will open up the shortage, and that will help with the shortage very much. So thank you so much. And one thing I would like to say is that if you are equipped to carry a load of bricks and you're carrying only a load of feathers, you're not fulfilling the civic duties of the society. Thank you.
Thank you very much for your testimony. Senator Mann, any other testifiers? I think that's all I have. The board is available for questions, but members, do you have any questions? Senator Abler.
Well, thank you, and Senator Mann and Dr. O, and I'm sorry I didn't catch your name, but and to the many, nice to meet you. And Madam Chair, and I've met a whole bunch of international docs, including like internationally known neurologists from Russia, and somehow they're just not quite good enough to work here, and we desperately need their services. I don't know how long I've been working on this, Dr. O. I mean, like 8 years or a long time, and so it's just nice that the planets have lined up to create this really good alternative. I'm not sure if the world was ready for it earlier on, but it's desperate for it now. And so I really want to commend you for carrying this forward, and to all the different boards and whoever's have put this together to make it work. It's time. It's a really good thing. And we're never going to have enough residencies. In fact, I'm sure you know this, but in the match, many students that are trained in this country do not get a residency. And now they have a degree with tons of debt. Now what do they do? And so it just compounds all that. So this takes all the politics out of it, and we can just get to work. So thank you very, very much. This is a remarkable bill, so thank you.
Thank you. Senator Kupek.
Thank you, Madam Chair. Thank Senator Mann for bringing this bill forward, and I'll go off of everything Senator Abler just said, and this is just one, I think, of many areas where we are not utilizing the skill sets of new Americans that are in our country, and it's bad for us because we have a worker shortage in so many areas, and if people aren't able to work up to their full potential of what they could be doing, that's not good for us. So I'm glad to see this bill, and I think there's probably a few other areas that we could also move forward with changing some of the licensure requirements to help people who've done this work in other countries for many years and are now here to do that same work here. So thanks, Senator Mann.
Thank you, members. Senator Morrison.
Thank you, Madam Chair. I don't want to prolong the love fest, but thank you, Senator Mann, for bringing this bill. I'm proud to be a co-author of it. In a year when we're talking about expanding scope of practice in a lot of different professions, here we have this wealth of already trained professionals in our state, and it's a loss to everyone in the state. I'm grateful to both of you for your work. Thank you for testifying today, and I really hope that we are able to get this done this year in Minnesota. We need your expertise and your skills. Thank you.
Thank you.
Thank you. Any other questions or comments? I guess I just had one question. It looks like in your amendment, Senator Mann, it adds more ability to have the licensee check in, and more robust requirements for that. I don't know, can you talk about some of the changes that you've made, and also relating to the insurance? Can you comment a little bit about that?
Yes, Madam Chair. So we had conversations with all stakeholders, including the Board of Licensing, and board members wanted to make sure that we had a robust way to check in on people, to make sure that they were fulfilling their requirements, to make sure that they're fulfilling their requirements. I'll leave it at that. And so we added this language about checking in every 6 months to make sure that people are still with the employer that they had their initial agreement with. And then the insurance piece, this is it would have happened already, but we just put it in the language that the supervising physician or the supervising entity, whether it's a hospital or a clinic, we just wanted to make sure that they are holding the liability insurance for the provider.
Thank you. Any follow-up or any closing comments? This bill will need to go to state government because there is some state agency enforcement that you added in the amendment.
Yeah, Madam Chair, just highlighting the fact that I'm sitting here next to a UN physician and a leading clinical researcher who cannot practice medicine in Minnesota. Talk about wasted human potential. So this is really low-hanging fruit on our quest to solve the workforce shortage. I think we're going to have to talk later on about loans for medical students, increasing residency slots, MA reimbursement, all that stuff. But this one is an easy step. So,
thank you. Well, I appreciate you bringing the bill forward and continuing to work on it. It does seem like a way, to help us, given that there is such an imbalance in the residency, and since people have such great backgrounds and training already, so I think it's good that we are trying to address their access in this way. So, your motion will be to move that Senate File 3611 as amended, be recommended to pass, and be referred to the Committee on State Government.
that is my motion, Madam Chair.
All those in favor, please signify by saying aye. Aye. Any opposed? The motion does prevail, and the Senate File 3611 as amended is passed and referred to the Committee on State Government. And now we will move to Senator Limmer. Senator Hoffman is in another committee presenting right now.
Sorry about that.
Welcome to the HHS Committee, Senator Limmer.
Thank you, Madam Chair.
Please go ahead and present your bill, Senate File 4199.
Good morning, everyone. Senate File 4199 is an attempt to restore a decision that was made by the Minnesota Supreme Court to restore the original intent of the Minnesota Health Records Act. And if I can unpack this a little bit as a brief history, it would be important to understand the context. As you might know, the Minnesota Health Records Act was enacted in 2007. It protects the privacy of patient medical records beyond the limited protections in the federal HIPAA law. HIPAA law does allow states to provide more stringent protections for our citizens. The MHRA, Minnesota Health Records Act, has been oftentimes controversial, and it's been amended over the years, but it has been in existence always with solid bipartisan agreement. This particular bill is being carried in the Minnesota House, and it recently passed its Health and Human Service Committee just a few days ago. In October of 2023, the Minnesota Supreme Court held that the MHRA allows the sharing of medical records without consent for the purposes of fundraising. Everything else requires consent from the patient in order to pass records along. But in this case, they decided, and that really is the rub of the decision, without consent for fundraising. It was highlighted in the case Schneider versus Children's Healthcare. The court's reasoning rests on what they call a statutory interpretation. I suppose I could say it, they found that the statute in this narrow regard was not clear enough, and they held that fundraising could use patient records for that purpose. The court said that where the MHRA prohibits the disclosure of protected health information without quote-unquote specific authorization in law, the legislature meant to include federal law, namely HIPAA. As you know, you have the HIPAA protections, and then you also have the MHRA protections, which are slightly more stringent than HIPAA in a few regards. The plaintiffs pointed out that the court's interpretation could permit the importation of other HIPAA privacy rule exceptions into the Minnesota Health Records Act, and essentially would gut the MHRA. The court said this was a policy concern that should be directed and legislated, or directed to the legislature. So, I guess simply put, this particular bill restores the MHRA by clarifying our intent that it be stronger than HIPAA, and that when the MHRA makes an exemption for something, it has to be done under the authorization in law, and by that we mean Minnesota law, not HIPAA. The bill does not change the MHRA in any other regard. It merely restores the law narrowly to what was always intended before the Schneider case. Madam Chair, as I sum up, I do have an A1 author's amendment that I'd like to bring to the attention. It's mostly technical.
Thank you. Yes, Senator Limmer has an author's amendment. Senator Mann moves the A1 amendment. All those in favor, please signify by saying aye. Aye. Any opposed? The amendment, excuse me, the amendment is adopted. Senator Limmer, any other comments?
Not at this time, Madam Chair.
Thank you. I do have one testifier, Rich Neumeister.
Madam Chair, members of the
welcome to the committee. Please state your name for the record and begin.
Madam Chair, members of the committee, my name is Rich Neumeister. Since the late 70s, I've been haunting the halls of the Capitol and working with you, past and present policymakers, on the broad issues of privacy and open government. In the mid-'80s, and it came out of the Senate in a bipartisan support, laws were made to where folks can get access to their medical records, to get copies of their medical records. Before that, they were controlled pretty much by the industry or the doctor or the provider. A lot of things changed in the 80s and 90s. Those laws were amended to do what Senator Limmer, Madam Chair, has indicated, where Minnesota became a bright light for 3 areas. Consent, where your constituents would get control of their most intimate information. 2, there would be also control of disclosures and more access rights to the broad term of what a medical health record is. Boom, in 1996, HIPAA came. So all those provisions in law, and ever since 96, the term specific authorization, council, reps, senators, the big councils of health plans, everyone thought it basically was with Minnesota. And it was like that for years. Then in 2007, Madam Chair, as Senator Limmer indicated, the recodification of the Health Records Act came. It was basically all the same law. It was just then now a recodification of that. And that was led by Representative Thiessen at that time. Then boom, the court decision. And what it does, it now eviscerates a lot of the protections, access rights, and allows more disclosure of our most intimate information without lots of the rights. So what this does, this bill, in a bipartisan support as in the House, and I believe it's here in the Senate, it just puts the lay of the land back where it is. And for those parties who want more rights in the health records deal, or those folks that want some modifications, let us decide. And when I mean us, I mean the people and you, the policymakers, rather than 7 folks in the building across the street on a very narrow thing. So, Madam Chair, members of the committee, that was my intent, just to give you a little bit of history to it. Secondly, why I think this is important. I want to thank you very much for the few moments of your time.
Thank you. Members, do you have any questions or comments? Senator Abler.
Madam Chair, this is like blast from the past day, it seems like here. And it's nice we can keep resolving these issues. And Mr. Neumeister, I mean, just God bless you for your over 40 years of being a private citizen caring about this matter. This is, but for the work of him and Senator Limmer and a number of us, we would have just records that could be almost posted on the internet. And not really, but just it would feel like that to people. So privacy is so important. I won't belabor it, but this work is key, and Senator Limmer, thanks for the bill, and I hope we can get this all through the process to keep our records intact. Thank you.
Any other members have questions, comments? Any final comments, Senator Limmer?
No, I know when to quit when I'm ahead, Madam Chair, and so I leave it up to the committee. Thank you.
Well, thank you for bringing the bill forward. I think it is, as Mr. Newmeister said, it's appropriate for us to take this action this session, if more work. I know that there are some who would like to see changes, but I think we should have a discussion about those in a way that's separate from this matter that came up, without our action. So Senator Limmer, let's see, Senator Mann, would you move that Senate File 4199 as amended be recommended to pass and be referred to the Committee on Judiciary and Public Safety? All those in favor, please signify by saying aye. Aye. Any opposed? The motion does prevail, and the Senate File 4199 as amended is passed and referred to the Committee on Judiciary.
Thank you, Madam Chair.
Thank you. Members, we have the last bill. Senator Hoffman is in Education and Finance presenting, and so we will recess for about 5 to 10 minutes. We are in recess. able to present.
Jason Rarick, I presented and I gave it to Jason Rarick, and then I popped over here. So sorry. Thank you, Madam Chair.
Members, we will reconvene the Committee on Health and Human Services. And Senator Hoffman, you are here to present Senate File 4124. Please.
Thank you, Madam Chair and members. I appreciate you going into recess. I was over in education, and you know what happens in education. They just talk and talk and talk and talk and talk. Sorry. Thank you. I'm glad Senator Liskey's laughing. Everywhere we turn, you know, we hear about mental health crisis, staff shortages, and the challenges to critical care access. This plays out across the state, but more acutely it does in rural Minnesota. In 2019, the Minnesota Department of Health noted in their report in 2019 that 0 psychiatrists has listed as practicing in rural areas of the state. While psychiatrists make up the most highly trained members of the mental health care continuum, physician assistants follow with 2,000 hours of direct patient care before a PA program. An additional 2,000 hours is part of their clinical rotation, each playing a critical role in that continuum of care. With critical shortages in psychiatric physicians and 0 listed as practicing in rural areas, the role of PAs in these areas becomes more essential, where care may be delayed by weeks or months. I think we can all acknowledge waiting for vital mental health care may not be an option, leaving these patients with no other options other than to shift the burden to our already overwhelmed emergency departments to fill this urgent need. Madam Chair and members, there is a solution. Minnesota PAs are trained and licensed to diagnose mental illness, prescribe medicines, and monitor a patient's response to treatment. PAs consult and work in collaboration with psychiatric physicians as appropriate and refer to the cognitive behavioral therapists to provide talk therapy or more holistic patient care. These well-trained practitioners with thousands of hours of direct hands-on experience in accredited programs can fill those critical gaps that we know exist. Today, those PAs provide 8.5 million patient visits, with 1 million of those visits in rural Minnesota annually. However, 2020 changes were made to the statute that have led to some considerable confusion, and that's led the lack of access for rural patients, delayed care, and higher dependence on expensive emergency care. This has led to a mismatch in which care settings are afraid to hire badly needed as due to administrative and legal confusions on their scope and their ability to follow through on care to the best interest of the patient. So that's why Senate File 4124, it's really simple. It removes Subdivision 5 of the Physician's Assistants Practice Act put in place in 2020, and it removes those limitations on PAs that are not consistent with our 49 surrounding states. That, Madam Chair and members, maintains that the current Section 3 PA practice agreement clearly defines the PA scope of practice, reviewed annually by a Minnesota licensed physician with knowledge of the physician assistant's practice to ensure that the PA is practicing within their scope, training, and experience. I want to note that the Minnesota Board of Medical Practice, who oversees physician assistants, voted unanimously to support this legislation. In a time of severe shortage, overburdened systems, and ever-growing mental health needs, we need to remove the confusion. We need to allow the nearly 4,000 PAs to act according to their training and license at a time when Minnesota most needs it, Madam Chair. The House Finance Policy and Committee, I just said the House, I can't believe I just did that. The other body heard the companion and laid it over for possible inclusion in their omnibus health bill. So, Madam Chair, I'm happy to discuss this bill, and with me is Leslie Clayton, who is with the Minnesota Academy of Physician Assistants. Thank you.
Welcome to the committee, Ms. Clayton. Please state your name for the record and begin your testimony.
Thank you, Madam Chair. Thank you, Senator Hoffman. My name is Leslie Clayton, and I'm a family medicine PA with 26 years of practice experience. I'm a PA educator and a health system administrator. I'm here today on behalf of the Minnesota Academy of PAs, representing Minnesota's 4,000 PAs licensed and regulated by the Board of Medical Practice, as well as the students at Minnesota's 5 nationally accredited PA programs. PAs are indeed trained to provide care for patients with mental illness in all care settings. PA training by national accreditation standards does indeed have requirements as part of our core training for specific curricula and clinical rotations specifically in mental health, and to say otherwise is not accurate regarding PA education. It's important to recognize that PAs are similar to nurse practitioners in scope in healthcare, and comparing us to any other profession is not relevant regarding training or practice. NPs have no physician oversight restrictions in their practice in mental health and are not regulated by physicians and have no required physician involvement in their education standards as PAs do. It's noteworthy that opposition has expressed no concern regarding the practice of nurse practitioners in this area of care. Here are the educational facts. PAs have on average 2 additional semesters of coursework and double the clinical training of our nurse practitioner colleagues. And I want to be clear, I am not being critical of our nurse practitioner colleagues' training or the practice that they provide. In my position as the program director of advanced practice, I have leadership oversight of more than 1,200 PAs and advanced practice nurses across a health system. And I say with strength of evidence, there are no safety concerns about how NPs or PAs provide service to Minnesota patients. If you trust the evidence that I do, that nurse practitioners provide excellent and safe care based on their education and practicing with no physician attachment or restrictions in mental health, then you should have absolutely no concerns about the safety of care provided by PAs, given our educational strength and proof in the research. For clarity, PA scope of practice is not in any way and shape in conflict with licensed therapists who provide therapy, whereas PAs practice medicine, not counseling. There is no conflict between therapists and PA scope of practice, and in fact, research identifies that PAs are more likely to refer a patient for therapy services than physicians in primary care are, adding strength and evidence to the fact that PAs are indeed know how to function as part of a multidisciplinary team, respecting the roles of our colleagues. The Minnesota Board of Medical Practice voted unanimously to support this bill, and if there is true concern about dangers of PA practice, they would know. In addition to being far outside of the norm of state policies, this restriction is also in conflict with federal policies. The National Rural Health Association, the Centers of Medicare and Medicaid Services, and the federal 21st Century Cares Act specifically defines PAs as, quote, high-need providers in mental health and needed to alleviate the mental health provider shortage. These federal policies and reimbursement rules provide proof that PAs are indeed trained, qualified, and needed to address mental health care needs across the country. Subdivision 3, the physician review of PA practice, is retained in this bill and still regulates PAs more strictly than our NP colleagues who provide the same scope of care. There are some current facts that I can share regarding a recently published study in the Journal of Medical Regulation in December of 2023 that concluded that allowing PAs to practice consistent with their training and experience was associated with a significant decrease in malpractice rates for both PAs and physicians. And a 2023 study conducted by one of the foremost respected research companies demonstrated that 92% of patients who were polled across multiple states support updating PA practice laws to fully utilize PAs and specifically acknowledge the well-rounded education that PAs provide to patients. In addition, the same study demonstrated that adults who had been seen by a PA supported PAs as part of the solution to addressing shortages of healthcare providers. I urge you to consider the facts about the PA profession. Research, federal policy, and the Minnesota Board of Medical Practice validate that PA training is safe and consistent with practice. This bill makes sense, and this legislative body and the patients of Minnesota can trust the facts. I thank you for considering this bill. I also want to thank Senator Hoffman for sponsoring it, and we appreciate your attention to assuring that Minnesota PAs receive the care that they need when the evidence provides that PAs do provide safe and cost-effective care in all areas, including in mental health. I'm happy to answer any questions.
Thank you. I don't have any other testifiers for you, Senator Hoffman, but we do have a couple testifiers who would like to express concerns. Dr. Michael Triangle, please come to the table. There's just one. One is online, Senator Hoffman, so, or, oh, we'd like to add another.
Yeah, you can.
Okay. Dr. Triangle, if you could.
State my name.
Please state your name for the record and begin your testimony. Thank you.
Madam Chair, committee members, Michael Triangle. I'm a psychiatrist, past president of the Minnesota Psych Association, currently head of the legislative committee for the Minnesota Psych Society. So I'm speaking for the Minnesota Psych Society, who strongly oppose this. One thing I want to sort of just highlight, if I could, from the get-go is we're really not talking about all mental health. You know, what you heard about is PAs are good people, they get trained. Only 4% of them actually specialize in behavioral health. So 96% have just general training. And what we're talking about is if somebody comes in with sort of like a bread and butter depression or anxiety disorder, we're not talking about restricting PAs at all. It's really truly just the most severe, intractable, kind of complex diseases where you really need specialized training to get a sense. So we're talking about schizophrenia, schizoaffective disorder, bipolar affective disorder, some patients with where it's hard to tell, is this personality disorder or is this an other underlying kind of thing, teasing out some of those things. So when this came up 4 years ago, I mean, there was a lot of talk about it, and at that time, the PA Association, the Psych Society, the Psychology Group, NAMI, Mental Health Minnesota, we sort of came up with this compromise, basically saying, yes, let's expand the scope, but let's limit it for these people that really need the most expertise and the people that are the most fragile and intractable to treat. In those 4 years, not much has really changed. Kind of when we heard from the PAs more recently, they talked about the hospitals, specifically Licensure and HCMC, requesting a change and being confused. But when we reached out and talked to them, I talked to Ed Colon at HCMC and Susie Serrett is one of the lead PAs there. And she said there might have been an issue in the past. We don't have an issue now. We don't need any change. The folks at Licensure, John Schmidt and Larry Hook, said, we haven't asked for any change. And Larry Hook, who's like their inpatient medical director there, said he had been approached by TAs asking if he would be willing to support it, and he said, no, these are the toughest diseases, and I don't support it, and I'm not at all in favor of it. And the Hospital Association said no one has requested it. They're neutral on the subject. It's really not being pushed. So one question I'm asking is, the reason to readdress this, that at least we were told about, doesn't seem to be accurate or at least a pressing need as far as we can tell. We do agree that there's a shortage and there's a difficulty with access of getting kind of expert psychiatric care. That's real. We've been doing stuff to try and improve that, expanding telehealth. One of the things, Senator Wickland, that I think you've helped us with starting 2 or 3 years ago was there's a new, very much evidence-based model of care called collaborative care management. And currently, certain insurance payers will pay for it. Medicare pays for it. Some of the private plans pay for it, but Minnesota MA doesn't pay for it. And it's a primary care-based model of care where you hire a care manager, you have a psychiatric consultant, you have a registry, and you kind of work. You basically leverage the psychiatric expertise to give oversight and some opinions. For each hour of psychiatric time, you can cover 80 to 120, talk about 80 to 120 patients, and for those that are stuck and not improving, you can give advice in it, and it's by far the most effective with better outcomes and earlier outcomes. And we're not anti-PA at all. In fact, in terms of my jobs, my last job, I just recently retired, was Senior Medical Director for Behavioral Health at Regions and other health partners, places and stuff. Before that, I did that at Alina as well. And at Regions, where we see a lot of psych patients, we realized we needed to increase the training of PAs and NPs that just had regular training, and we created a one-year fellowship that's been very popular and very successful, and we've been able to have people train there and then work with us, inpatient and outpatient. And we tend to think that, remember, we're talking about the toughest, most intractable sub-slice of mental health issues. And where we really are concerned is sort of expanding the scope to all patients, especially in clinics where there aren't psychiatrists around, where they can provide some oversight and give advice, which really tends to mean when we're talking about when there are practice agreements, which if you remember, it's like 96% of PAs aren't trained to specialize in behavioral health. And their practice agreements are with primary care docs, who in turn are also asking us, we need access, help us, and we're trying to work on that. When we went and looked at sort of how much training seems to be in the curriculum of PA programs, when you look at the websites of Augsburg, where there are 31 courses throughout the training for PA, one of them is devoted to behavioral health or psychiatric issues. If you look at Mayo, it's 2 out of 30. So I guess what I'm saying is we like PAs, we've been hiring them at Regions and in Health Partners. Some medical systems like Alina have a stand right now where they won't hire PAs because they think they haven't been trained adequately in behavioral health stuff, whether inpatient or outpatient. We know we need to figure out ways to do that and expand it, but not with no oversight and not for the toughest, most difficult diseases. We've heard sort of like, you're not reading newspaper headlines about harms that have happened with this. And I know that when we've talked about it as psychiatrists, we've had a number of psychiatrists sort of talking about patients that haven't done well. And it's generally been patients that are in kind of greater Minnesota, where their collaborative agreement is with a primary care doc. And one of our docs talks about her brother, who has tough substance use disorder as well as bipolar. And the PA repeatedly kind of stops the medication to stop. The brother takes naltrexone to stop cravings for the drinking. And then he gets his cravings overwhelmed him. He goes on a binge. He stops his medications to keep him stable for his manic depression. And he's gone through 4 cycles of this. And that particular individual just seems to not want to even listen from advice from psychiatrists when they're trying to offer it. As medical director at Alina and as medical director at Health Partners and Regions, I can tell you that most PAs do a good job, but there are always some that don't like to, that want to sort of be independent and don't want to consult, and that's when their problems tend to arise. And we've had a number of examples of people missing tardive dyskinesia, which is a potentially irreversible side effect of taking antipsychotics, giving pregnant women.
Dr. Schmeichel, can you conclude?
Can I snap it up and close it down?
Thank you.
Sure. So I guess what I'm saying is it's a small slice of folks that are the most severely mentally ill. We need to provide some safety while at the same time we're trying to expand the access in ways that we know are safe and work.
Thank you. We have also Sue Abderholden is online. Would you, I don't have you on the list, Mr. Amber. Can we have Sue testify and then we'll come back to you? Ms. Abderholden, if you could please state your name for the record and begin. Thank you.
Thank you, Madam Chair. Member Sue Abderholden, Executive Director of NAMI Minnesota. NAMI Minnesota and Mental Health Minnesota have serious concerns with this bill as written. We fully understand the dire need to increase access to mental health care and to build our workforce, but we must take great care not to compromise on the quality of care. We would welcome any PAs who are interested in psychiatry to take the steps to show they are committed to mental health care of their patients by undergoing additional education and training. However, the bill in front of you today does not require any extra training or certification for PAs to make significant clinical decisions for children and adults with serious and complex mental illnesses. PAs take a 2-semester credit course in psychiatry and do a 4 to 6 week rotation on psychiatry. This is very different than APRNs, who are required to choose one of 4 roles and then choose one population focus, one of which is psychiatric and mental health. The University of Minnesota Psych APRN program is a doctoral level program, and most of the 81 academic credits are on mental health and 960 of their 1,000 hours are psychiatric-specific patient care hours. Other mental health professionals, such as social workers, are required to have 4,000 hours. Our primary concern is allowing them to diagnose and treat children and adults with serious mental illnesses like schizophrenia, bipolar disorder, major depression, and other diagnoses that include psychosis. If your child is experiencing delusions, what qualifications would you want their medical professional to have? The simple answer to this is not a physician assistant who is a generalist, but someone who is a specialist in mental health, someone who has had extensive training. It is common experience for people to first discuss their symptoms with their primary care physician, but even family physicians are rightfully cautious to diagnose or treat children or adults with these types of serious illnesses. A 2013 legislative report found that PAs are underqualified to serve people with serious mental illnesses. Our state is not more restrictive than other states. In fact, their national organization cites that only 3 states are rated optimal, and Minnesota is the second category, with over 20 states being rated as more restrictive than Minnesota. There is no reason to repeal this section of the statute. They can diagnose and treat simple depression and anxiety. They can actually continue treatment for people with serious mental illnesses. They just can't diagnose and develop that first treatment plan. There are some certifications that PAs can obtain in psychiatry as recommended by their national organizations. We have in the past suggested amendments to require more experience or certification if PAs would like to practice a larger scope. Their national office suggests things like completing an additional 1-year clinical rotation in a psychiatric health setting, completing a postgraduate fellowship, completing the NCCPA's psychiatry certificate of added qualifications, and passing the NCCPA National Psychiatry Specialty Exam. The existence of these certifications show that many PAs take mental health care seriously. We are very open to collaborating to increase access to care, especially in this time of crisis. We hope that we can find a solution that allows PAs to practice safely and with high quality of care that we expect in Minnesota. But this bill does nothing to guarantee that. And in the end, the patients, children, and adults with mental illnesses and their families will be the ones at risk. Thank you for the opportunity to testify.
Thank you. Mr. Amberg, did you wish to provide testimony?
Yeah. Bill Amberg with Amberg Law Office. I represent MPS and the Minnesota Psychological Association. I couldn't get a psychologist here on short notice, so I'm going to do my best. But just a couple of things, because I was there less than 4 years ago when this compromise was negotiated. We just entered the pandemic and kind of came out. We're trying to learn how to Zoom, communicate the way we weren't used to. And there was a lot of confusion in the air. So there was a hard-fought compromise, which is Subdivision 5, that's been law for not even 4 years. And it's unclear to the mental health community and the mental health professionals why this change is required. We heard about some hospital systems had some confusion. When we talk to them, they don't. We heard a reference to shortages in rural Minnesota. We don't have any psychiatrists in rural Minnesota. We have 2 of them on our legislative committee, which isn't very big. But since the pandemic, one of the few good things to come out of it was what we learned about telehealth, and we were all a part of that. Senator Morrison passed the PsyPAC bill when she was in the House. Senator Benson, who I saw earlier, was the Senate author, to allow compact states for PhD licensed psychologists to reach out to rural Minnesota patients. We've learned through the data that's been coming in that in behavioral health and substance use disorder, telehealth works extremely well. In fact, there's some patients who have trouble making it to a face-to-face meeting with their psychiatrist for med management or their therapist for psychotherapy in person. So as we continue, and Dr. Trangle referenced collaborative care management, Senator Boldon's been the chief author of that project. We got part of it passed last year, we're back again this year. That's a great way to get more psychiatric expertise into the primary care environment. And we urge you to bring her bill up for a vote and pass it in the session. So in the House hearing, we heard references to therapy. Hopefully the PAs clarified that it's not in their scope of practice to do psychotherapy. It takes thousands of supervised hours of supervision for psychologists, licensed independent clinical social workers, and other therapists to be able to do that in their scope of practice. So if that's true, that they don't believe that they can do that, that would be an important finding today. Anyway, I know we're over time, so I'll leave it there.
Thank you. That's all of the testifiers that we have. Senator Hoffman, come back to the table. And then members, do you have any questions for Senator Hoffman or testifiers? Senator Utke.
Thank you, Madam Chair. Thank you, Senator Hoffman. I think this is a good deal. I like this bill. I listened to the various testifiers, and I think in some cases we're trying to pool everybody into the same bucket, and that's not what I believe is being proposed. PAs can do a wonderful job within their scope of practice and their training. They're not wanting to go above and beyond what they're trained for. We've sat here and listened to that in other scope and licensure bills here in the last week. Once again, they're just wanting to be able to, one, we know we need the help. We've got a terrific need out there, and if it's within their capabilities, they're willing to do it. If it's not, like in any group, they're going to recommend and refer to a higher level. You know, I see so many times, and maybe it's just my opinion, but we become awful protective of our own little area when somebody else is trying to lend assistance. And it would be different if there was no work for the others, but in this case, everybody is overworked, and there's not enough providers. So I think this is good. I have not heard of a way that anybody was respectfully injured, hurt, mistreated throughout a process if somebody wasn't up to the caliber. And, you know, I heard that maybe some of the PAs weren't doing a good job, but I think we could say that about every level in every profession. Not everybody is 100% at the top of their game. So we can't hold that against the PAs just because somebody maybe didn't diagnose just right. So at this point, I thank you, Senator Hoffman, and I think this is the right move. It's a good move, and it's going to benefit us across the state.
Senator Hoffman.
Thank you, Madam Chair, and thank you, Senator Ike, for your observation, and you once having the same kind of scope conversations when you were chair of this committee. It's there. When you hear words like "I oppose" and you hear words like "we're against," yet at the same time, the same people saying that are saying, well, there's a deep need. I mean, a letter was just delivered to our office this morning about the clinical needs that are there, and it's like somewhere in the middle, there's got to be a way to work around this. Stop getting, the personalization side of it. It needs to be personal, and your observation is specifically there. You got the experts out there that need help, and you got folks that we have over here that are generalists that can, guess what, add to that helping thing. And I think there's a few of us that have discussed, I know Senator Liskey has always talked about, that deep need that's out there. The generalization of the PAs are absolutely a huge help to fixing our problem with access in the state of Minnesota. So thank you for your words, Senator Utke. And I think to that point, Madam Chair, I hate scope bills, or if it's not a scope bill, but any of these kinds of bills where you're getting that piece against a piece. And what it really should get us is that those entities should go and take a self-reflection and say, well, what is it that we can work on here for the betterment of Minnesota? Jim Ramstad always taught us that, man. Leave that personalization, leave that ego in the hallway, and get what's done for the specific need at hand. And we have a deep need in Minnesota. I think this is all members on deck at this time, Madam Chair, so thank you.
Thank you. Any other members have questions? Senator Liskey.
Thank you, Madam Chair. Madam Chair, I think this question probably best directed at Ms. Clayton. I guess when we're talking about scope or not scope, or however you want to define this bill specifically, I'm reading through the statute 147A.09. There's a bunch of subdivisions. Subdivision 3 requires you to basically refer back to or be overseen by a physician. And I'm under the assumption that physicians are okay and they're allowed to treat mental health disorders properly and diagnose and things like that, which means that your license is directly relying on their decision-making, and their license obviously oversees your license. So I would just argue that subdivision 5 is really just a harsher redundancy or a harsher limit on something that you're already technically limited under by subdivision 3. Is that correct?
That is correct, sir. Subdivision 5.
I'm sorry, I
apologies,
just
Madam
have
Chair.
to.
My apologies.
Ms. Clayton.
Thank you, Madam Chair. That is correct, Senator. Thank you for the questions. Subdivision 5 specifically restricts PA practice in the area of mental health conditions across all settings, including care that we would provide as an ERPA for a patient who might be having a psychotic break. And there's no other area of medicine where PAs have a restriction on the complexity of the patient that we can see. We see complex patients for cancer care, deteriorating neurologic conditions, severe cardiac conditions, and there's no clause that's challenging our safety for those patients or the evidence that PAs don't know how to partner appropriately. It is a redundancy for Clause 5 compared to Subdivision 3. And the language is confusing because none of the terminology in Subdivision 5 is definable. We don't know what ongoing means. Is that 2 visits? Is that 5 visits? We don't know what serious mental illness means because it's not defined in statute. And with regards to the comparisons for educational standards, family nurse practitioners who have less education than we do not have any restriction at all or any physician attachment to their practice, and they provide care in mental health care settings just like PAs do.
Thank you. Senator Liskey.
Thank you, Madam Chair. Madam Chair, I've got a couple, well, maybe one more direct conversation on this. And I find it interesting, we hear the word generalist in the discussion today, and generalists aren't able to handle the cases because it's too general and it's not specific. They don't have the educational background to handle the specialty that is this mental health disorder or that mental health disorder. But the reality is that without generalists, we don't actually have any reason for a specialist to get referred from or referred to. So, you know, the primary care physicians, we all have a duty as primary care physicians to properly understand and diagnose what we're facing and then refer out if it's out of our scope. I see patients all the time where I have to refer out due to scope issues, and I do. I don't want the liability. I don't want to treat that patient for something that I know I cannot treat. And I would like to think that all providers, especially PAs included in that, know where their limits are, and they should know when to ask for help. I mean, I was at a PA over 3 weeks ago for an injury to my foot. You can see I'm wearing a cast, and the PA knew what it was. He was 100% certain on how to treat it, and even with that, he still called the overarching orthopedic surgeon just to double check his diagnosis and his treatment course. So I can't imagine that that would be any different in most cases. I mean, obviously we all know that every profession has a situation where there's a rogue this or a rogue that, and it happens. But in this case, I think it's just strictly trying to say, hey, we're PAs, we know what we can do, and we just want to be able to do what we can do best. And so that's why I support this bill. Thank you.
Senator Abler.
Thanks, Madam Chair. Are we voting on this today or just being laid over?
Senator Abler, no, we're laying it over.
All right.
It doesn't need to go anywhere else. So.
That's fine. I just have a question. So I'm probably 60-40 on this deal. Some of these scope things are really, you know, hard. You want to make sure people are safe. But I have a couple questions for Ms. Clayton just to help me understand. So this Clause 5, so has this been a problem? I mean, I appreciate, you know, what you're trying to do. So, like, are there times that the overseeing clinician that you're trying to get a hold of doesn't pick up the phone, or they say no? Or is it just they always say yes, pretty much, and then you just got to find them? Can you answer that for me?
Ms. Clayton.
Thank you, Madam Chair. Thank you, Senator. 2 parts to the question, if I may. So has the clause been a challenge? Yes, it is a challenge for health systems and policies because we don't know how to write our PA practice privileging to accommodate Subdivision 5. We don't know how to meet the criteria of what collaboration means. And subdivision 5 applies to all PAs in all practice settings, not just those practicing in psychiatry. So if a PA in primary care sees a patient for what they have concerns as serious mental illness, and they make a referral to psychiatry, but psychiatry does not have an available appointment for 3 to 6 months, they may indeed see that patient back in that interim, which could be defined as ongoing care of serious mental illness. But they've made a referral to a psychiatrist and they're pending that appointment. So have they met the criteria of subdivision 5? Or are they practicing outside of scope because they're continuing to provide care in an area of shortage? So that's where subdivision 5 is creating challenges for health systems to understand how do we get the PA's practice agreement written to specify that we're meeting these arbitrary and unclear restrictions that were put into our statute during a political negotiation. So the other question that it begs to ask is, how are we being challenged by that? So we were indeed contacted by health systems, multiple health systems, who said we're confused about this statute. As we moved forward to try and correct where the challenges are to strike this clause because it is redundant to our practice agreement, the process carried out and the support was not fully vested. But other health systems do support it. And you do have a letter from a psychology group or psychiatry group, Nystrom and Associates, that indeed does work with PAs and does support removal of this confusing clause.
Madam Chair.
Senator Abler.
Well, that's very helpful. This reminds me of the dental therapist debate, if you recall that. And it was, if there were plenty of dentists taking medical assistance, there would be no dental therapist program now, but there just weren't enough dentists who were willing to work, frankly, below cost to take on these individuals. And with respect to the good doctor who's here, I get what you're saying, and I understand your commitment to high quality. But there's just not enough of you, I don't think. And I think in this gap evolves the PA, and there probably is an element of risk in there. But I think that the safeguard in here is a collaborative agreement. I don't think a lot of docs enjoy getting sued over what their PA is going to be doing. And so I think that that's the safeguard I see in this thing. And so if you can create a mill of, like, I think DHS has one psychiatrist running the whole place. So anyway, that's just, and thank you, Madam Chair, that's all I have.
Ms. Clayton, did you have something you wanted to add to?
If I may, thank you, Madam Chair. The strength of oversight is the fact that we are regulated by the Board of Medical Practice and that there is physician involvement in every aspect of PA education, which is unlike our colleagues in medicine. We have a program director that must be a physician in every accredited PA program, and there are physicians who sit on our Accreditation Review Commission and on the National Committee for the Certification of PAs. Physicians are involved all the way through. So we have oversight beyond even the practice agreement to know how to collaborate in care. It's not a question as to whether we're trained for that, because the PA profession was founded on the premise of collaborative care. We don't need an additional redundant clause to remind us to do the standard of care, which is to elevate the patient to the care that is essential for their needs.
Any other member questions, comments? I just had one question, Ms. Clayton, about the practice agreements. My understanding is that the practice agreement is between a physician and a specific physician assistant. I mean, each physician assistant has to have that practice agreement, or maybe you can explain to me how the practice agreement process works. I'm interested in knowing if physicians are, would they be willing to sign off on practice agreements if they felt that there was a concern about the training or the ability of a physician assistant to take care of people in all the situations that they encounter. If you could tell me more about that. Thank you.
Thank you for the question, Madam Chair. The practice agreement, as it's specifically written in statute, it requires a definition, a description of the scope of practice that the PA is going to be providing in that care setting. So if the PA is going to be working in psychiatry, their practice agreement will call out and define what their scope is going to be. If they're going to work in primary care, their scope will be appropriate to that. If they're going to be working in surgery, and so on and so on. The practice agreement statute specifically states that it must be reviewed on an annual basis by a licensed physician who is familiar with the PA's practice. And it is written in that way so that health systems can navigate the extra paperwork required to employ a PA in a way that makes the most sense for the area of care where they're providing it. It does not specifically attach a PA to a specific physician. It creates accountability of review of PA practice. We specifically, when we changed the bill in 2020, removed physician liability because it doesn't make sense to charge another profession with the liability of the practice actions of a different profession, but it does provide in the practice agreement that intentional connection that the PA is indeed practicing within the scope with which they were hired. And it's specific in our statute regarding our scope that we are to practice within our education, training, and experience.
Thank you. I don't have any other questions. Senator Hoffman, did you have any other final thoughts?
No, Madam Chair, I appreciate the conversation, and clearly, you know, you got, what do we have, 40, 50 scope bills to work on this year, so.
Madam Chair.
We have a
Madam
Senator
Chair,
Abler.
the doctor was trying to reply to something, if you don't mind. I'm interested to hear what he was saying, and
Okay.
as a comment, if that's okay.
Dr. Trango.
It's really two quick comments. I think we see the need, this is why at least at Regents, we started a fellowship that's been very popular and filled and people trying to get in to do it. And I just want to also point out, our concern is very few of the practice agreements involve psychiatrists. Most of them involve primary care docs or sometimes other specialists in other fields where mental health issues come up. And unfortunately, mental health issues come up everywhere, all the time. You know, it's not really limited. We're talking like there's a psychiatrist they're going to be able to reach out to if they have a tough patient and get some, just call on the phone, get some advice, some oversight. And more often than not, it's not readily available for most people. It is with their primary care doc or maybe their OBGYN, but not necessarily the psychiatric expertise. I mean, which is why we were really pushing the fellowship. It hasn't taken off everywhere, but we know that works.
Thank you. Senator Liskey.
Thank you, Madam Chair. I had no intention to comment more, but after hearing that, I kind of wanted to address that. I'm a primary care doctor by being a chiropractor. I have patients that walk in with any list of things. And kind of what you just said, it kind of concerns me. I always have a psychiatrist that I can call. I have a psychologist that I can call. I have an orthopedic surgeon. I have a neurologist. How is that different than what a PA would have? I'm just concerned that what you just said kind of is confusing because I have the ability to reach out if I need help and oversight. I can instantly call any list of my contacts that I have in all of the fields that I don't specialize in. So why would a PA be any different in that aspect?
Are you asking Dr. Trango? Dr. Trango?
I know that when I started doing collaborative care and going weekly to North Suburban and also in Tyra, in St. Paul, Dr. Hernandez, the medical director at Tyra, said, "You're the first psychiatrist I've seen in the flesh in years." He says, "I can't get him on the phone. It's just very hard." And it's much easier for people that are in the metro area than in greater Minnesota. I wish I had an answer, you know. But.
Senator Liskey?
Thank you, Madam Chair. So basically what I'm hearing is it can happen. PAs can have the connections to the psychiatrists that they need to have connections to. I mean, I practice in rural Minnesota. I do. I practice in a small town of 4,500 people. I still have a connection that I can reach out to. Is it easy? No, it isn't. But that's what the specialist issue is right now that we're facing in the healthcare industry is all specialists are overbooked. I mean, it took me 3 weeks to get in with an actual orthopedic surgeon, not with a PA. It happens. That's part of what we're experiencing, and I think that's what the PAs are here to try and offer a solution to, is that we don't have access immediately. And so the generalists are important because they provide an immediate access and then proper access to the right care. So thank you.
Senator Hoffman, any final comments?
Thank you, Madam Chair and members, for this conversation.
Thank you, Senator Hoffman. Senate File 4124 will be laid over for possible inclusion in a future bill. And that being the end of our agenda today, we are adjourned.